Oh, it's not working. Okay. So good afternoon. I would like to thank the opportunity to be here sharing this research topic. The focus is to analyze the symptom severity level in peripheral artery disease patients in a muscle oxygen saturation point of view. So peripheral artery disease is an atherosclerotic disease that causes a decrease in blood flow due to narrowing or blockaging of the arteries, and it's associated with the intermittent claudication, that is exercise-induced pain that is relieved with the rest. Is very common symptom and is often used as a criterion of the severity of the disease, and also a criterion of the improvements related to exercise programs or exercise therapy. The intermittent claudication can be unilateral or bilateral, and when bilateral, usually we have a more symptomatic leg, and usually the most symptomatic leg is considered in the walking tests and walking evaluations. So the severity of the symptoms, including the leg pain, typically corresponds with the ankle brachial index, a non-invasive tool to assess vascular status, but is related to more macro circulation. So calf oxygen saturation can have relevant information related to the microcirculation status that is not achieved with the ankle brachial index measurements. So the aim of this study was to compare the calf oxygen saturation between the most symptomatic leg and the less symptomatic or no disease leg at pain-free walking distance, the distance taken when pain emerged, and maximal walking distance, the distance taken when the pain is almost no longer bearable for the participants during an incremental protocol. So 22 men with symptomatic peripheral artery disease in the stage 2B of front-end classification were recruited for this sample. It means that they have claudication, they have pain at a distance shorter than 200 meters. They were not currently exercising, and so they were recruited for the study. Important to say that most symptomatic leg ankle brachial index was 0.64, and for considered participants with disease, the level of ankle brachial index should be lower than 0.9. So they have moderate disease. The experimental protocol has fulfilled the following phases. So after ethics committee approval, instructions to the participants and familiarization sessions, the Gardner-Skinner incremental treadmill protocol was performed until leg pain limitations, exhaustion, or other important symptoms. The instruments that were used, I'm going, and we consider the 20 seconds data of the maximal walking distance load for maximal walking distance heart rate response, maximal heart rate achieved during this protocol. For average muscle oxygen saturation, we use all values of the initial load, 3.2 kilometers per hour with 0 slope, pain-free walking distance, and the maximal walking distance loads that were different between participants. We calculate the oxygenation amplitude, the delta muscle oxygen saturation with rest and lower value difference. And we will present the minimum muscle oxygen saturation, the lowest value achieved during the protocol. And following a statistical approach. For legs comparison, we use the t-test, of course. So The heart rate was different from rest to maximal walking distance level. It was not a surprise, but it's important to refer that the majority of participants achieve very light intensities in the last load, and they need to stop because of the pain, because of the claudication. No difference were found between legs. I refer most symptomatic and less symptomatic or no disease legs or symptoms. And this initial load is important because this is a constant in all the participants. And this is the same external load for all the participants. For future comparisons, probably this is a very important information. And no difference were found between the most affected and less or no diseased legs. At pain-free walking distance, the gastrocnemius muscle oxygen saturation was different between legs. The geometric shape of the most affected leg is less wide than less wide ranging than the less or no affected leg. Probably we have a mix of severity of the symptoms in the no disease or less symptomatic leg, probably important for future analysis and future studies. At maximal walking distance, there are difference between the severity of symptoms legs and the revealing, of course, a specific oxygen kinetics in this most affected leg. The amplitude of deoxygenation is also different between the symptoms, the severity of the symptoms, and we can see a huge desaturation in the most diseased leg. And we can confirm in the minimum oxygen saturation value achieved during the protocol. The minimum oxygen is different between legs, and with several participants achieving very, very low values during the protocol. Perhaps could be important to say that this minimum oxygen saturation value in some participants, it's achieved in the first level of intensity, in the first load, and in others a little bit late. So it's we have some variety of results. So as a conclusion, light to moderate intensity heart rate responses to Gardner-Skinner protocol is important for us because we are working, we are exercising with the disease participants, so the intensity is important for us. Gastrocnemius muscle oxygen saturation, impaired microcirculation is higher in the most symptomatic leg, both in pain-free walking distance and in maximal walking intensity. We believe that a division into more separative groups may be required to make better use this muscle oxygen saturation information. And this physiological information can add quality to the exercise prescription, allow to monitoring and individualizing the exercise dose, and improve exercise adaptations. We understand that long-term improvements of microcirculation, this type of variables can add relevant information to ankle brachial index that it's not very changeable with the exercise, and potential limitation of this study, different macro and micro circulation status of the comparison leg, because we add for the same group less symptomatic levels legs and no disease legs. So when we have a more robust sample, probably we can separate these groups. Thank you so much for your attention.
Thank you very much. Papers open for discussions. Other questions from the audience?
Thanks for the presentation. Just touched on it again.
Okay.
A little bit. You don't have the content mostly talking about the effects of exercise. Your thoughts on the changes in ears.
Mm-hmm. 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 The literature showed us that the ankle brachial index it's not changeable. So we are thinking about detecting angiogenic adaptations, so microvascular adaptations, instead of changing the big vessels of the main arteries. So we believe that we can add relevant information, and we have some few participants that we have long-term data, and without statistical power yet, but we can see some variation. We can see some changes in the muscle oxygen saturation and other derivative variables that we are determining. So I think yes, could be interesting to continue to study this. Thank you.
More questions?
So, did all your people report have the gluteus or other local?
In this specific group, this specific study, all of them, they feel the pain in the calf, all of them. But in the biggest sample that we have, some of them have in other leg zones, but it's more frequent in the calf, in the gastrocnemius. Thank you.
Final question? No? Okay, so thank you again.
Thank you.
Final speaker.